Thank you for being here today. We are very pleased to have three distinguished speakers sharing with us in this seminar. They are Professor Marco Itze from the University of Minnesota, Professor Shirley Ho from Nanyang Technological University, Singapore, and Professor Gary Krebs from George Mason University. In light of the COVID-19 infodemic, the three of them will take turns to discuss both theoretical approaches as well as effective interventions to handle similar crises in the future. In this seminar, the three speakers will go first, and we will open the floor for discussion after the presentations. So first, we have Professor Itzer. He is a professor of the University of Minnesota's Hubbard School of Journalism and Mass Communication. He also holds an affiliate faculty position at the University of Minnesota's School of Public Health. Today, he will share with us the usefulness of the recent action approach for COVID-19 messaging in Asia. So please, Professor Itze.
Thank you very much. So let's see if we can make this work. Looks like I'm successful here. Delighted to be here. My name is Marco Itzer. I'm with the University of Minnesota. Thanks for having me. If only we could have an opportunity soon to talk with each other and have a discussion in which we could, in a more physical environment. It also is a privilege to me to be on this panel with Professors Ho and Krebs. I think that between the three of us, we will be able to give a fairly comprehensive overview of more the fundamental issues related to health communication or health crisis communication. Among those essential things to address in health communication are questions about message content, like essentially what do we say? Questions about a message source, so who needs to say it? And questions about approach and format, so how do we say it? And just to give you an idea of what will be happening, I think that we will see complementary views and ideas. I will be focusing largely on message content. So what is it that we would need to say in the context of COVID-19 messaging? A useful start in this case is to see how experts in crisis communication tell public health communicators what best practices might be. And often we go back to Peter Sandman and Jody Leonard's principles of crisis communication. It's useful to just take a quick look at some of these principles, in part because some of them seem to be counterintuitive. So according to Sandman, one of the first principles in crisis communication is not to over reassure. Somewhat related to that is not just to accept that there is uncertainty, proclaim that there is uncertainty, be very explicit about uncertainty. And if there's one thing that we have learned this last year about COVID-19 is that this is a pandemic characterized by great uncertainty, and everything that results from that. Be open about dilemmas and share with your audience that, well, we can do this, but with these consequences, we can do that, and that will have those consequences. Validate emotions. COVID-19 has come with significant emotions stemming from all kinds of sources. Validate your audience emotions as well as your own. Because everything is new, we will need to try things, and not all of them will succeed on the first go. Own those errors and apologize for them. And then last, give your audience agency, empower them, so involve people. Offer your audience a menu of things that they can do. And I'd like to spend some time on that last part. So offer your audience a menu of things that they can do, or put differently, give your audience behavioral options. Now, interestingly, if there's one thing that we have seen in COVID-19 messaging this last year, globally, across the globe, is that in health messaging about COVID-19, we have been giving people behavioral options. Here's an example from Hong Kong, I believe, that I think is illustrative of a common approach in COVID-19 messaging. We see very similar approaches across the globe, and for the right reasons. What you see here is an example of providing an audience with behavioral options. What are the things that we can do? stay at home, see a doctor when unwell, wear masks. By now we have come to know all of these behavioral options. Now, so from a health messaging perspective, if the objective is to encourage people to engage in these behaviors, then we need to first understand what the factors are that explain why people would or would not engage in these behaviors. And the idea is that those are the factors that we then may need to address in messaging. There is an interesting observation to be made here, though. So if you look at common COVID-19 messaging approaches, and here's an example from the US, is that much of that messaging does give people behavioral options. By now, I think we have educated ourselves in terms of what are the things that we may be able to do. And this is a typical example, talking about a range of different behaviors. What that implies is that apparently if we would engage in these behaviors, then we would protect ourselves and others against COVID-19. Doug Story talked about this in terms of response efficacy. So if we engage in these behaviors, then that may be efficacious in terms of protecting ourselves from COVID-19. We also see illustrated how you may be able to engage in these behaviors. So a skills-oriented approach, if you will. What it implies is that messaging like this, that gives people behavioral options, but not much more, assumes that response efficacy, beliefs about response efficacy, and beliefs about skills are the factors that explain why people wear masks or do not wear masks, keep their social distance or do not, etc., etc. And I argue that that may not be an assumption that we should just, that is not intuitive. This is where behavioral theory comes in, or behavior change theory. It is an individual level theory, so it tries to explain individual behavior, but as Doug Story in the discussion just emphasized, these behaviors see individual behavior in a context of a social ecology model in the sense that our individual behavior fits in, sometimes as a function of the larger structural environment in which we live, and that includes culture. According to behavior change theories, it is absolutely critical that we give people these behavioral options, tell people what it is that they can do. In addition, behavior change theory tells us that to do that effectively, so to effectively move people towards engaging in those behaviors, we must identify those factors that explain those behaviors and address those most important factors in messaging. So what are those factors? Here I focus on one of the most widely used behavior change theories, reason-action theory. According to reason-action theory, ultimately behavior is a function of behavior-relevant beliefs. And to quote Marty Fishbein and Isaac Eisen, the conceptual fathers of this theoretical tradition, those beliefs have to do with the extent to which you think that, let's take the example of wearing masks. Wearing masks has positive outcomes or negative outcomes. The extent to which you think that people who are important to you, your family, your doctors, and so forth, whether the extent to which they approve or disapprove your wearing masks, whether they actually wear masks themselves. And beliefs about the extent to which there may be factors in the environment that make it more easy or difficult to wear masks. And the idea is, according to reason action, that we should identify those beliefs that are most important in explaining wearing masks. Now, these belief systems, according to reason action, reflect everything that we have come to learn to associate with wearing masks, which means that a year and a half ago, belief systems about wearing masks to protect oneself from COVID-19 were empty, because there was no such thing as COVID-19. But quickly, over time in the last year, our belief systems about wearing masks has become quite expensive. And to give just an example of that, this is from research just published by Howard in the British Journal of Health Psychology, who developed a scale. He focused on negative beliefs about outcomes of wearing face masks He identified over 30 of such beliefs, and these are only negative outcomes. He didn't even look at positive outcomes. So clearly what we see here is that the belief system that we have, that people have about COVID-19 protective behaviors, such as wearing masks, can be quite extensive and go well beyond beliefs about response efficacy and skills. This illustration brings you to an important point that will be responsive to some of the questions that we just saw in the discussion after the previous panel. Let me illustrate. So what that behavior relevant belief focus implies is this, two important things. One, each different behavior has its own foundation of behavior relevant beliefs, which means that the beliefs that we have identified for wearing a face mask may not necessarily be the same as the beliefs that the same people may have about staying at home, social distancing, and so forth. The implication is for health messaging that once we have identified the behavior that we want to encourage, we need to do research to identify the beliefs that underlie that particular behavior. If we want to encourage multiple behaviors, we need to research those multiple belief systems underlying each of these behaviors. Somewhat similarly, not only are beliefs unique to behaviors, beliefs are also unique to people. So from one person to the other, you and I will have different beliefs. There will be overlap, but we also be unique in the beliefs that we hold. From one group to another, beliefs differ. From one culture to another, beliefs differ. And this is where reason action theory, in fact, is a culturally sensitive theory. Although it was developed by someone who lived in the United States, this is not a theory that was designed to explain, let's say, Western or Northern American phenomena. What the implication is this. So we cannot rely on research about beliefs that was done in the United States if we want to intervene in, let's say, China. We cannot even rely on research on beliefs that was done in one particular part of China if we live in a different part of China, because cultural values may differ. The implication is that research needs to be done in the cultural group that we are interested in to identify the beliefs that are relevant in that particular population. Here's a visual diagram of the theory. You may have seen versions of this before. This is the current version of reason action approach. It builds on earlier versions of the theory of reason action, theory planned behavior, the integrated model of behavior prediction. The current version of the theory was introduced in 2010. Now, I'm not going to walk you through everything. What is important for the purpose of this particular talk is this. Like, you see a whole lot of things going on, but ultimately, what this theory says, again, is that behavior is a function of the highly specific beliefs. We may have a large set of beliefs about wearing masks that we learned over time to associate with wearing masks, and they automatically and unconsciously translate into a readily available for memory evaluation. For example, in terms of how good or bad I think wearing masks is, how enjoyable or unenjoyable, how full is wise. These beliefs, normative beliefs, translate unconsciously automatically into an assessment of overall social support for or against my wearing masks. These beliefs translate into an overall assessment of, can I do it and is it up to me? Why this is important is that ultimately it's at the level of beliefs that we see the implications for health messaging. A health message, the content of a health message is one or more of these beliefs. And then ultimately addressing those beliefs that most importantly explain behavior should translate in behavior change. So I emphasize in that because I really want to make the point that to use this particular theory well, in a sense to be useful for informing message design, we need to have research that measures those beliefs. Now, what is fascinating to me is that a theory that essentially says that behavior, that's what we want to explain, is a function of beliefs. It's not how most of us use it. This is how most of us use it. There are thousands of studies in the reason action tradition And the vast majority of those studies measure intention, attitudes, norms, and control, and then use regression analysis to see how important each of these variables is. That's very important to have that information, but it cannot speak at all to which one of these beliefs ultimately underlines these mechanisms. And given that it is at the level of beliefs that we see implications for health messaging, there really is what I call a big part of the potential of reason action to inform COVID-19 messaging remains untapped, because most of the research doesn't look at beliefs or even behavior. So at this point, I think it's clear to you that apparently I'm a believer in beliefs. I think there's great value in taking seriously the idea that if you can find behavior relevant beliefs, then that may be useful for informing messaging. You may counter argue and say, well, we live in an era in which misinformation is rampant. And we have seen great presentations yesterday on a topic. My colleague Emily Fraga introduced really interesting possible ideas to debunk some of this misinformation. So misinformation is around us. Should we not focus on beliefs in misinformation rather than beliefs about the behavior? Well, and there is something to be said for that. For example, in a piece by Xiaoli Nan and her colleagues that is to appear in the Routledge Handbook of Health Communication, Xiaoli did a narrative review of beliefs in misinformation and what it was associated with. And she was compelling in demonstrating that beliefs in misinformation, that misinformation affects how we think about health issues. So it leads to misperceptions about health issues. Similarly, we have seen correlations between misinformation and such things like intention to vaccinate against COVID-19. So does that mean, though, that misinformation causally affects COVID-19 protective behavior? So the more we believe in misinformation, the less likely I would be to wear masks? That is an important question. It sort of seems implied, but interestingly, it has not been tested that often. Recently, Bob Hornig and his team did test this, and Hornig, in his own way, had an interesting way of talking about the implications of this question. So does information causally relate to COVID-19 protective behaviors? Well, if that is the case, Hornig says, then we may need to identify ways to combat misinformation. Emily Fraga's work. But then he continues. He says, if not, then perhaps communication strategies might instead focus on targeting other kinds of beliefs. And he took a reason action approach. He says behavior beliefs. So how did Hornig put data to this question? In the summer of last year, he implemented a perspective design. At the first wave, he asked a large sample of US adults, in this case, about beliefs in COVID misinformation and about behavior beliefs from the reason action. And 6 weeks later, he asked these same people about whether the extent to which they had maintained social distance and the extent to which they had been wearing masks in public places. And what Hornig found was that, yes, at a correlational level, you can demonstrate correlations between misinformation and behaviors, but that correlation disappears once you account for behavior beliefs consistent with reason action. And maybe even more interestingly, in a time-lagged perspective analysis, Hornig showed that behavior beliefs predicted change in both of these behaviors, so with a 6-week time lag, whereas misinformation did not predict behavior. And I just loved how Hornig, in a somewhat provocative way, offered a conclusion or an interpretation of these findings. He writes that these findings suggest that a communication intervention directly addressing misinformation beliefs is likely to be less promising than one directly addressing the specific behavior beliefs around the protected behaviors. And he says, in addition, addressing misinformation beliefs is unnecessary in the context of health campaigns because any influence they might have on behaviors is accounted for by the direct behavior beliefs. That's that's a bold conclusion and goes really against what many of us have been working on and think. I'm not sure I agree fully with Horik. In fact, I am sure that I do not fully agree with Bob Horik in this case. I think this was a really useful study, though. To me, what this says that is it adds validity for the relevance. It adds support for the relevance of a reason action focus on those behavior relevant beliefs. They are causally related to COVID-19 protective behaviors. But I would argue that because misinformation has been shown to be a source of those behavior relevant beliefs, for example, the more I may believe in misinformation, the more that may affect how I think about wearing masks. So it's a source of those beliefs. It is also very important to consider that source and address misinformation. So to conclude, what needs to be done? I agree with almost what has become a theme in this conference, I think, is that we shouldn't have a singular focus. We need to recognize that individual behavior ultimately what people do is what people do. So I think that argues for a focus on individual behavior, but we must understand that in a context of people's reality, and that is culture, but it's also a physical environment that may include simple things like are there even masks available where people are. So I argue for a multi-tiered intervention approach that also looks at the environment to identify factors that may be addressed, that may keep people from acting on their attention. But then again, research is needed that identifies behavior relevant beliefs in the cultural group of interest to inform the COVID-19 messaging. We have the conceptual tools for it, and we have the empirical tools for it. The research methods have been documented and aren't even that expensive or require very sophisticated skills, so to speak. How should we then, once we have those identify those beliefs, we have message content. So what do you say? How should we deliver those messages? I think this is where complementary knowledge from crisis communication comes in. And this is why I'm very much looking forward to hearing Shirley and Gary tell us how to do that. Thank you very much.
So thank you, Professor Isaac. Thank you for the presentation on the importance of behavioral relevant beliefs. So lastly, I would like to welcome Professor Krebs. He is a University Distinguished Professor and Founding Director of the Center for Health and Risk Communication at George Mason University. Today, he will share with us the role of health and risk communication in responding to pandemics and other serious health crises. So welcome, Professor Krebs. I think you are currently has your audio muted. Okay, I think you're ready to go.
Let me see if I can get my thing back.
Yes, you're back.
Unfortunately, that's not showing up on my screen right now. See if I can get it to show back up. Yeah, my slides are not showing up on my screen.
Yes,
so I'm not sure exactly what.
We can only see the PowerPoint, the software, but not the.
All right, I can okay. See it here. All right, thank you very much. I think my talk will complement what Marco and Shirley had to say, because I'm going to take kind of a population health perspective that's kind of a more macro approach. They both took kind of a more micro approach where they were looking at individual perceptions. And I'm going to be thinking about ways that we can frame messages and ways that we can communicate to try to address the complexity of pandemics. And I'm going to take kind of a global focus because I think that the recommendations and applications that I'm going to talk about are equally applicable to just about every part of the world. On the other hand, we realize that the different countries and different regions of the world handled the current pandemic in very different ways. Some of them were much better than others. In fact, many of the Asian nations did a much better job responding to the pandemic than a lot of the Western countries, including the U.S. And so I think that when I talk about recommendations, each person should be thinking about how do these apply to my own situation? How do these apply to my own country? And how do they apply to international health promotion agencies and organizations? So let's see what I can do here. Is my slides moving? All right, here we go. All right, we on my first slide? Say yes or no.
Yes, yes, yes.
Good. Okay. So pandemics are tremendously complicated health problems and crises, and we need to think of them as strategic communication situations that we need to try to reduce misinformation, promote understanding, encourage adaptation so we can avoid the infodemic problems that have been happening around the world. I ground a lot of my work in a theoretical perspective on sense making that's based on Carl Weick's model of organizing, which is a really powerful theory that talks about communication as a sociocultural adaptation mechanism for dealing with complexity, uncertainty, what he calls equivocality. So pandemics are almost kind of a definition of equivocality. It's a brand new set of issues, problems that we have not encountered before. We really don't know what's causing the pandemic. We don't know what to do about it. We don't know how to prevent it. We don't know how to treat it. We don't know how to stop it. It's a huge buzzing problem. And so in those situations of extremely high equivocality, communication becomes really critical so that we can derive the best available information for making decisions about response. Unfortunately, when we encounter major problems like pandemics, there's a tendency by many governments to not communicate in an open, transparent, and helpful way. Often they're really thinking about what can I do to kind of maintain control? What can I do to minimize the problem? How can I maintain my reputation? How can I preserve my power? As opposed to thinking about what do we need to do to keep people informed and help them think. And so communication often is not used as a way to resolve the pandemic. It's often used as a way to kind of minimize or discourage people from thinking about the pandemic. But it's kind of like the situation where the ostrich buries its head in the sand when there's a sign of threat, thinking that because the ostrich doesn't see the threat, the they will no longer be in danger. But obviously that does not occur. The more that we hide from the threat, the more that we obscure the threat, the more that we miscommunicate about it, the worse the threat becomes. And that's why we've had more than 2.5 million people die from the current pandemic, and it's continuing to grow. And yeah, and we really haven't learned from past mistakes. There's been tremendous problems and bad decisions that's been made along the way. Just this past day or two, the two states in the U.S. decided that even though we've only gotten our vaccine out to about 7% of the public, that they were going to open things back up. They were going to say the state of Texas and the state of Mississippi no longer require people to wear masks anymore. They're going to bring things back to normal, which is insane because the data don't suggest that that's what we need to do. They're hiding again. They're trying to obscure the problem. They're trying to minimize the issue rather than communicating in an honest way. So I'm going to talk today about ways that we can reduce confusion, ways that we can share relevant health information, how we can help people, know what they need to do and give them motivation and rationale for following direction. How can we empower people to manage their own risks and promote coordinated health promotion responses? I think that we need to communicate in ways that will help us develop integrated health practices and policies, as well as to establish guidelines for dealing with pandemics in the future. We need to recognize this is not the only time we're going to see a pandemic. This is not really the first time that we've even seen the coronavirus. Within the last 20 years, we've had two major problems. We had the Middle Eastern MERS coronavirus, and we had the Asian coronavirus that both were really precursors to this problem. Luckily, in both of those cases, they were not as dangerous. They were not quite as infectious as this variant of the coronavirus. And so we didn't really think about what to do. But because we knew about those things, we should have been making plans for dealing with this kind of problem if it rose again. And we didn't do a good job of that. So let's talk about sense making and equivocality. One of the most critical factors in dealing with the pandemic is to raise public awareness. And not just recognizing that there's a problem out there, but recognizing that this is a salient problem for them. This is really based on the health belief model, that there's an issue that's relevant to us, that it's salient, and that's important to respond to. For a long time, many leaders in many countries, including the United States, the leaders are saying this is not a big deal. This is just going to go away. Don't worry about it. It's just like a common cold. It's just like the flu. You don't have to worry. We've got it under control. This is a problem that's happening somewhere else. It's not something that's happening here. But clearly that was not the case. And eventually the information came out, but it was hard to kind of rectify the misinformation that was provided. It was hard to change people's minds because it was a very optimistic message. It was the kind of message that people wanted to hear. People don't want to hear gloom and doom. They want to hear happy messages. Don't worry, be happy. And so, but those don't worry, be happy messages are really criminal. They're dangerous in times of serious threat. So we need to provide relevant and timely information about what is this all about? What do we know right now? What is the best available information about the basic mechanisms and influences of this virus? How does it operate? What can we do about it? And then we need to engender cooperation from many different sectors of society, from the business community, from the healthcare community, from the police community, from the general public, from healthcare providers, so that we can all work together and do our part to address this complicated and pervasive social issue. So I'm going to talk about strategic communication as the primary way. And when I use the word strategic, I really mean evidence-based. We need to do evidence-based, smart communication to promote a good response to the pandemic. We can't be just talking off the top of our heads. We can't just say the first thing we hear about. We can't just tell people what they want to hear or what makes them feel good. We've got to provide the best, most relevant information. And the three major things we need to think about, we need to provide information to prevent the spread of the pandemic. And we really missed the boat on that one. As I mentioned earlier, this is not the first time the coronavirus came around. We should have been doing many things to stop the coronavirus from spreading. We knew a lot about what were the causes. Where was this coming from? How is it spread? How is this related to zoonotic, an animal-based spread of the disease? And we could have done a lot about that. We also knew a lot about preparation. How could we prepare to deal with this problem? We knew that this was a respiratory problem, that we needed to have proper equipment to help people, prevent, like the use of masks. We needed to help people, have the right kinds of treatment. We should have had respirators available. We should have been providing support and encouragement to a variety of different fast response mobilized units to deal with this problem. And then we needed to train people to respond effectively and coordinate activities to respond when the pandemic happened. None of those things happened. Certainly not in the US, not in many European countries, not in many Latin American countries. And that's why we've had such a terrible adverse response to the pandemic with widespread infection and many deaths and tremendous suffering. And that suffering is not going to go away because we know that there are many long-term effects, both physiologically and psychologically, to this pandemic that are going to continue to occur even after the vaccine has taken hold. And that's the vaccination process is happening tremendously slowly. So we need to minimize misinformation. Misinformation has been the biggest problem. We learned about that yesterday when Emily Vraga talked about it. It came up again today, both in Marco's talk and in Shirley's talk. And so what do we do about misinformation? So, communication is really both the source of the problem and also the solution to the problem. Bad communication leads to misinformation, and good communication can minimize and respond to misinformation. So we need to find ways of identifying when there are problems with good sense making, and then provide meaningful information to reduce maladaptive approaches and responses. We also need to figure out ways of retaining the best information and utilizing it in the future to guide future efforts instead of trying to reinvent the wheel. One of the problems we had with the former coronaviruses is that we did not retain what we learned. We didn't make that institutionalized. We didn't develop programs and policies for responding quickly. And so when this pandemic happened, we didn't have anything ready to go. We had to start all over again. So I think that misinformation can be offset with regular, timely, accurate, and caring information. It sounds a lot like what Peter Sandman said that Marco talked about. We need to provide good information in a caring, sensitive way that also lets people get involved so they can make good decisions and gives them options. We need to identify what is the best, latest information to share. It's very difficult to communicate effectively about the pandemic when we don't have access to the best information. And recognize that this is a moving process. Is that more information is coming out as we move forward, as more research goes, as we get more experience. We learn more about it. So, you not just a one shot, here's the information, goodbye. We need to keep updating it and let people know that we're learning more and get them ready to accept new information. Explain what we currently know and tell people why it's a risk for them, what they can do, and then let them know when we get updated information. We need to use the best communication strategies that are appropriate to the different audiences, recognizing that there's no one way to communicate effectively with everyone. So that means that we need to have multiple different communication strategies that are targeted to different segments of the population based on their beliefs, based on their attitudes, based on their education, their literacy levels, so that we can communicate with them effectively. And most of all, we need to realize that people are under duress. They're scared, they're worried, they're hurting, they're seeing death and suffering, and we need to demonstrate respect and compassion for them. And this is not easy to do when we're in an emergency. People want to bark out orders, but we need to realize that people may not be ready to accept that information. And we need to show compassion so that we can communicate in an empathic way that people can accept and listen to us and be able to realize that we're trying to help them. So the first thing I think we need to do, and this was terribly violated in the US, is to have credible health experts provide the information. The source of the information is really credible. Who was the major source of information in the US for the first month or two? It was somebody who knew nothing about healthcare. Somebody who had no background in this era, somebody who was most interested in maintaining his authority and his credibility, who thought he knew everything about everything and didn't want to seek information. Unfortunately, it was the president of the United States who had a really disastrous effect on the dissemination of information. And he held a very strong control. He was the one who spent most of the time during the briefings. He was the one who minimized the voices of people from federal health agencies. And that had a huge problem. So we need to, recognize that during a pandemic, this is not a political event. This is not business as usual, that this is a time when we really need the voices of science. Just like Shirley was saying, science is really critical at these moments. And we need to provide regular channels and forums for disseminating the best scientific information, the latest information. We need to use all available channels of communication: television, radio, print, online, digital, social media, and in person communication channels, both from a top down and a bottom up approach, involving people from their own communities and their personal social networks. This is an all hands on deck communication activity. We need to actively monitor messages so we can understand when is misinformation happening. This is a form of infodemiology. It's like epidemiology, but about communication. We need to track communication. Uh, who is providing misinformation? What are they saying? How are they disseminating it? Who are their audiences? Who believes them? If we don't have that information, it's going to be very difficult to counter misinformation. But having that information provides us with direction. It's another example about where communication research should be guiding our communication efforts. So we need to develop and utilize powerful tracking systems, automatic ones that will track, and also ongoing evaluation research teams that are evaluating where public misunderstanding is coming from. We need to identify which are the messages that contain misinformation so that we can provide corrections. And we need to develop the best communication strategies to reach and influence people with the corrected information. We need to develop feedback systems, and this comes right from Carl Weick's model of organizing. He argues that when we're dealing with equivocal situations, we need to engage in meaningful interactions. Every communication cycle that we engage in provides us with new information and reduces uncertainty, helps us to understand more. And so we need to have places where people can ask questions and seek information. It can't just be a one-way channel. And so we need to get people involved in online forums, telephone hotlines, community meetings. We need to have educational sessions throughout society where people can get involved, ask questions, and adjust and adapt over time based on new information. We need to provide regular updates to educate people about new information and also to reinforce adoption of health promotion recommendations. In the US, we've had a really bad problem of people not following recommendations. There were a lot of people who didn't really want to be told that they couldn't engage in business as normal. They couldn't go out to the bars. They couldn't go to restaurants. They couldn't interact with people in the ways that they normally do. There were a lot of young people who felt that they had a right to party. There was a huge problem during the spring break last year where thousands of college students decided that they were going to violate recommendations and go to the beaches and have parties and get drunk and do all kinds of things that were fun to them, but they became a major super source of spreading of the virus. And we had lots of those incidences. And many of the leaders within the United States were encouraging that behavior, encouraging people to reject recommendations and saying this was a violation of their human rights. And so it was a huge problem to try to keep people in line. But we needed to provide regular, strong, and powerful information from a variety of sources to make sure that the guidelines were implemented, and then to update and implement new guidelines as new information occurs. And this is an ongoing process. That's why I say at the bottom of the screen, rinse and repeat as needed. This is not just a one-shot activity, it's an ongoing communication process. So I think there's a variety of things that we need to do to deal with this, not only now, but in the future. We need to develop the infrastructure for rapid advances in knowledge about health and risk communication and to make that information available. We need to test a variety of new communication strategies, models, and tools for disseminating health information. We need to disseminate the best information to the audiences who need it the most. And then based on that, we need to implement the best communication practices, policies, technologies, and campaigns. This is a process of discovery, development, and delivery. I think if we can do this, we can make a huge difference. But we need to start thinking about this now. We're already seeing new variants to the virus that are occurring that are going to complicate our recovery from this pandemic. And we need to be able to communicate about that very clearly so people know what to do about it. Here are some references of some of my work that is underlying what I've talked about today. These are some very recent and also some old chestnut articles that I've written that I argue about these different strategies about how to communicate complexity during health crises. Thank you all very much for your time and your interest, and I look forward to answering any questions that you may have.
Thank you, Professor Krebs. And for participants, feel free to start typing in your questions via the chat box, and we'll answer those questions later. And I think to kind of wrap up the three talks, I think openness and transparency is kind of a key theme today, because kind of, with the transparent media sources or we can have, form maybe more correct, right, behavioral relevant beliefs, and that kind of answers the concerns among the scientific community as well, right? When they have to engage the public to avoid backlashes. And of course, this speaks to all the concrete suggestions suggested by Gary, Professor Krebs today. So while people are still maybe thinking about the questions, just a very general question for all of you. Do you have any, very general suggestions for health communication scholars or even, practitioners kind of in the field of, risk and crisis communication in a general sense, right? It can be as, kind of theoretical inquiries that we should investigate more, or, what are kind of emerging methodologies, right, that they should be digging in, or any kind of practical suggestions for health communication scholars, especially junior ones, right? Just maybe we can start with Professor Iser.
Sure. This is a broad question. So let me focus on part of what you asked with respect to maybe professionals. And so one interesting challenge that we may have as health communication scholars is how can we translate what we think we know about health communication so that it has applied value in the real world. And I think that in our own way, we are all trying to do that. Given that it's a very broad question that I think can have multiple possible tactics, if you will. The thing that comes to mind, I think that is useful to maybe use when talking with health professionals who may not have a background in communication science is the axiom of thinking like your audience. In some way, everything that we have heard this conference has to do with we need to understand our audience. And so what resonates with our audience in communicating health, we often, particularly when we have a public health or a medical background, we communicate based on what we know is really important to know. But that seldom translates to what our audience may be interested in, motivated to accept, or even being able or capable of processing. Think about all the work on health literacy. So often a very simple reminder to ourselves is think like your audience. What does your audience need? What is their reality? And what might resonate with them? And very often that means that we need to seriously reduce the information that we share. That's the first thought.
Thank you very much. So Gary, maybe you can go next then.
Yeah, I think one of the things I would recommend is that you really engage different audiences, organizations, leaders. I think this is a time where communication knowledge is desperately needed, that people really don't understand what we mean by strategic communication. They don't really understand about issues like audience segmentation. They don't understand audience analysis. They don't understand about utilizing different channels of communication in complementary ways. They don't understand what we mean by feedback systems. I think many people are operating in a very simplistic way about communication. They really believe that if you just tell people things, that they will understand you and listen to you, which almost never happens because everybody's got their own perspective and they have different sources of information. And so they don't recognize how fragile the communication process is, and they need help. They need help from communication scholars to help them understand and to strategically design communication programs over time. That's just my 2 cents.
Yeah, and just to add on to what Gary and Marco mentioned, I think that in terms of theoretical approaches, Stephanie, that was your question, right? Theoretical approaches. I feel that there are opportunities in the online sphere right now when it comes to looking at theoretical approaches. There are lots of studies that have been, completed in recent years where they looked at, big data analysis, like Twitter analysis, analysis of Twitter data, and but I think most of these studies are very descriptive right now, and there are opportunities to develop stronger theoretical frameworks to explain those opinions. It could be misconceptions, misperceptions of the general public towards the pandemic. So right now, I methodologically and theoretically, I feel that there is a gap over here because most of these studies tends to be descriptive, and when that happens, then it limits our generalizability of these studies to future outbreaks. So I think that could be something that we could look at. And of course, what Gary and Marco mentioned about these modes of communication to the general public. I think these are tried and tested methods that are evidence based, and these these efforts should definitely be continued. Yeah, but I'm just reaching out to the online sphere. I feel that there is a missed opportunity over there.
Thank you, Shirley. And I think there's one question for Shirley about the impact of fake news in Singapore on knowledge, behavioral, beyond exposure to it. I guess you kind of approach your presentation kind of approach it from the views of scientists, right? And I think Sharon is here. Maybe you can add on to the question if you like.
Hello,
Sure.
Sharon. Yeah.
Yes, this is just partly an excuse to say hello to Shirley. I haven't seen you for a long time, so welcome to HKBU. First of all, let me say that I agree completely with your recommendations about the need for scientists to be and to get involved more in science communication and for other media professionals to actually facilitate that. Yeah. But my question has to do with your diagnosis, and there I'm missing a few steps in the argument, I guess. I mean, you cited the very troubling data from Pew Research in the US, and then coupled it with research in Singapore about exposure to fake news in Singapore. But of course, the Singapore context, as you know, is very different, right? It's not as polarized politically as it is in the US or even in Hong Kong. The government in Singapore is far more trusted in Singapore than in the US or in Hong Kong. And your own study, if I understand correctly, examined perceptions of risk of fake science, but I wonder how you've corrected for, say, the third person effect. As you know, in all censorship studies and media studies, people tend to overestimate how impactful everything from pornography to fake news is on others, even if it doesn't actually affect their own behavior. So beyond and beyond perceptions of risk that may in fact be tainted by the third person effect, what does the data in Singapore show about how impactful misinformation and fake science is on Singaporeans' knowledge and behavior in this pandemic? Is there, for example, concern about vaccine hesitancy or vaccine denial that researchers like yourself link to the prevalence of fake science?
Hi, Sharon, thanks for your question. I think I need to clarify that in our survey, actually, we did not look at vaccination uptake. So for the particular study that I mentioned in my talk just now, it was more about public's perception of the severity of fake science news and how that would motivate them to seek out more information, to incredible ones, to verify the fake news that they actually think that they have been exposed to. So with regard to vaccination uptake, I think most of the things that the information that I provided was from various sources, and of course published studies as well. There were cases. I think there was one study where I showed that Lumba and his colleagues showed that they ran an experimental study, and with the fake information that actually impacts their vaccination uptake. Yeah, which I have not studied it in the context of Singapore. So it was just, trying to draw generalizations from these Western studies to the context of Singapore, which I think, that would actually open up new areas of research. Yeah, so moving forward, that might be an interesting research question that I can explore in a future study. Yeah, but the connection that I make with scientists, I'm trying to advocate for a stronger role of the scientists in this fight against the infodemic, because what I see missing from the entire piece right now is that we have not been engaging the health experts and also the scientific experts, the scientific community, to the extent that we would like to. In this fight against the pandemic and perhaps also the infodemic. So I think there's room for engaging with this scientific community. And I'm not just talking about scientists, but also maybe social scientists and communication scholars like ourselves as well.
Okay, so next we have a question for Marco, but I think this question might be answered by Gary as well, right? So I think they are talking about the interplay between individual level, persuasion theories and societal level, just like, what Gary has mentioned, all the macros of, how can we, is it necessary as suggested by Yue? Is it necessary to extend, one to the other? And if yes, right, how can we do that in a better sense?
Yeah, I think it's a great question, an important question, and those of you who were there yesterday morning or last night, depending on where you were, Jeff had some interesting things to say about it. When I listened to Jeff, however, I have a slightly different take on this. If you look carefully at many of the individual level-oriented theories, you will see that the influence of social structural factors is acknowledged. For example, in the reason action theory that focuses on intra-individual processes, there is an important role assigned to something that is called background factors that includes multi-level variables, culture, religion, demographics, personality, and so forth. So what it means is there are important levels of influence beyond or higher than individual level influence that are recognized by individual level theories. The reason why I would be careful not to explode these theories in a theory that explains everything is that a theory that tries to explain everything explains, at the end of the day, really nothing. We now have tools that can help us in what I would deem in complementary fashion. Multi-level modeling is now a statistical technique. It's very sophisticated. It requires incredible resources to plan a multi-level design, but it is a technique that also is a way of thinking. Multi-level analysis sees ultimately individual behavior as nested in different levels of influence. So instead of everything matters, it carefully lays out what variables may be important at the individual level, what variables may be important at the social level, what variables may be important at the let's say the structural level. It's a technique that if you have indicators, you can in fact demonstrate how much of the differences in what you're hoping to explain resides at each of these levels. And I will end with just one comment on how useful your question was. With thinking about individual level as nested in social levels of influence, that is very useful for trying to think when message-based, individual level focused messages is even appropriate. As a quick example, if the political situation in a country is largely responsible for the risk for health that people face, then is it really appropriate to try and change people's behavior in the context of something that is larger than them that has caused it? So there are ways that we can determine whether behavior, individual level approaches, and that is really message-based interventions, are even appropriate. So I think that our current theories are actually able to account for that. See human behavior as a really large jigsaw puzzle. And theories that are designed to address different pieces of that puzzle. And I think really in complementary use of different behaviors. I hope it wasn't too rambling and that it was somewhat useful.
Yeah, I'll give a really quick response. I think that there's some individual persuasion theories that can be extrapolated to larger audiences. Even though we may be focusing on the individual, I think a lot of the social influence processes can be extended across multiple people. But there are also some larger, more aggregate theories that are more systemic in focus, like the diffusion of innovations model, or the social networks theory, or even the information gap theory that you might utilize to examine application of social influence among larger groups of people.
Okay, thank you very much. And one very quick, I kind of wrap up the last two questions as, during the pandemic, we can see lots of COVID-19 research coming out, right? Overwhelming of, scholarly findings. A lot of them might be preprints and people take it like seriously. And I think there's one question about, the credibility of the field, right, of our scholars. So how do you see this phenomenon, and is there any way, or what can we do as, health communication scholars in the field? How can we increase or enhance our credibility in the society? How about Gary? Do you have any
How about
thoughts about
Shirley?
it?
Shirley hasn't spoken in a while. I don't want to hog the floor.
Yeah, sure. I think there are many different approaches, yeah, so I think with a lot of special issues and with different journals, there are lots of new papers coming out on the COVID-19. Some are conflicting, provided conflicting information, and that might fuel public uncertainty. But I think in a practical sense, it might be possible for government agencies to take a much more active role in this case, because they could be the fact checkers, the official fact checkers. For example, in Singapore, our government has an official fact checking website, and body that will actively look for misinformation out there and actively debunk some of them. So I think practically these are some of the active things that government agencies and authorities could do. And also, of course, credible news agencies with good reach could also play a role here. They could help to do fact checking at the same time in tandem with what government bodies are doing. And of course, authorities like WHO could also actively source for these misguided preprints and have credible scientists and health experts to come online and speak about their views towards these how would I say, conflicting informations or controversies that, some of them, they know that it's not scientifically based, it's not evidence, the evidence is not strong enough. They could actually come up to explain, which is the more accurate interpretation of findings and what the public should believe in. So I think there is a need for scientists and health experts to step up in this respect, and not just bury it, in the muddled pool of preprints and not come up to say something about what they think. But at the same time, I also think that media literacy is important. It highlights the importance of media literacies for the general public. If they are able to be much more discerning, whenever they come across information from the internet, they should be able to tell, from various different information about a piece of information, whether this is credible or not, and whether this is believable or not. So I think these are some of the things that we could look into.
Yeah, I think I have two responses to this question. One is I don't know how many people are actually reading the communication scientific literature. I think that mostly we read it, our own work and the work of people we know. I don't think it's really reaching a large public. I don't really think that many policymakers are reading the communication journals. On the other hand, I think that as communication scholars, we have a responsibility to evaluate, review, and analyze the material in our areas of expertise. And I think that we need more review articles. The Communication Yearbook series for years used to preview articles that would review a large body of research and reach conclusions about what we learn. Communication theory also did some of that work. I think we need to do more of that kind of work. Right now, I'm working on a systematic review with some colleagues. We've been doing research recently on suicide prevention, the ways that we can use online communication. And there's so much muddled information about it. We're doing a systematic review to say, what do we currently know about this? What's been demonstrated? And what are the best practices, basically for our own purposes, so we know what to do with it. And I think other people need to do those kinds of systematic reviews as well.
Okay, so I think times is almost there. Or Marco, do you have anything to add?
Maybe real quick, and this is in response to the question about what if health communication not even recognized as a credible area of studies in particular part of the world. I think that even in the United States, where we may feel that health communication is accepted, we see that, for example, we still need to explain to our colleagues in public health that there is such a thing as communication science. To me, key to this is when you are working on health communication and your field is not even recognized, is one of collaboration. Help people understand what communication science is, and that may mean that that is rough, that is hard, but work in organizations that are actually doing communication, but people who are doing communication going to realize they're doing communication. Simple ideas in explaining, like Gary was saying, what audience segmentation is, what message design is that we take for granted now, are eye openers to people who are not used to this. So I think that stepping out of our comfort zone or our talking to each other, we speak the same language, but go to people who do not speak communication science language. I think that goes far in establishing credibility.
Yes, thank you very much. And I think the preprint issues may be relatively mild in health communication, but think about the science, scientific findings about COVID-19, whether to wear or not wear masks, right? There were very many conflicting information. And I think at least in Hong Kong, sometimes media sources or, random internet users, they might just pick one up, right? Pick a finding out and disseminate it, and they have the interpretation. And the next day they might find something out, contradicting, and that might make, the whole scientific community look really bad. So I would like to thank all of our speakers, Gary, Marco, and Shirley. We are really grateful for the time and effort you took to share your thoughts with us. And before we leave, I would like to make sure if you have your camera on, we can take a group photo together. And while you guys are turning on the camera, I would like to say, the sharings were really timely in light of the pandemic. I believe all of us, especially, junior health communication scholars, can benefit from this seminar. So thank you again for your contribution. So let us take a group picture right now. Look at the camera and smile. Okay, 3, 2, 1. One more. 3, 2, 1. Okay, I think that's it. Once again, thank you everyone for joining us. Our next section will start at 1:30 p.m. Hong Kong time. Look forward to seeing all of you soon. Thank you again, Marco, Gary, and Shirley.
Bye.
Thank you, Mark.
Thank you, Stephanie.
Thank
Thanks,
you.
Leanne.
And Jolie.
Thank you. Bye.
Yeah, bye, Icha.
Bye.
Bye, Marco.
Bye, Shirley.
Thanks for those friends who come from North America, because I know many of you might not be able to stay so late to attend the last panel. So particularly, let me, just use this chance to thank you again. Thank you. Bye-bye. Good night.
Good night.
Thank you. Bye. Good night.